PCOS, PMOS is a metabolic disorder. And this new understanding is now acknowledging that insulin and glucose metabolism need to be managed largely with lifestyle. It's acknowledging that there is a cardiovascular risk that is expanding far beyond just our ovulatory years, right? So in theory, can start before puberty and can extend until the day you pass. And so PCOS, when we're just looking at like cysts on the ovaries being something, that is a lot of times a really confusing thing to then manage when you're not bleeding, because I have hundreds of patients who have been told they don't have PCOS anymore when they go through menopause. It's like a graduation day. I'm like, it doesn't, no.
Welcome to the Advanced Women's Health Podcast, where we empower women with the latest insights and advice on holistic health. From cutting-edge medical research to practical wellness tips, our mission is to help you thrive at every stage of life. Join us as we explore topics ranging from hormonal balance and reproductive health to nutrition and mental well-being. Whether you're seeking solutions for a specific health concern or simply want to enhance your overall wellness, you're in the right place. Let's embark on this journey to better health together. This is the Advanced Women's Health Podcast.
Hello, everyone, and welcome back to the Advanced Women's Health Podcast. I am so excited to come on today and go through some updates with you. I'm actually going to be doing a few solo episodes coming up, one on our new onboarding system, one on the new launch of a metabolic health program that we have, which is super exciting. And then today I'm going to update on some news that came out recently that I've gotten a lot of questions about. So let's dive in. Today, we are going to talk about PCOS, or polycystic ovarian syndrome, now being renamed as polyendocrine metabolic ovarian syndrome. And so the whole renaming culture of medicine, I think, is something that's important to look at in general. So when we're talking about the name of something, it's a very important tool in a lot of ways and not important in a lot of others. So let's break it down. When we look at things like calling something polycystic ovarian syndrome, there's immediately an understanding in your brain that needs to change. And so that's why we looked at changing the name. Because one, technically the little follicles, they're immature follicles that are on the outside that we call a ring of pearls. So historically, there used to be this diagnostic criteria when you had an ultrasound, and it was like there was like a pearl ring around the outside of your ovaries. And so they used to call those cysts. They're actually immature follicles. So what happens is you're not getting consistent or efficient communication from your brain to your ovaries. And so you're not maturing one follicle to ovulation. And so a whole bunch of little kind of false starts happen. It's not perfectly accurate, but that's a great way to summarize it. And so that's what I'll break down for patients. But these are not cysts, and not everyone has them. And so this created a big problem, because when you say polycystic, many cysts, there was immediately this diagnostic kind of lens that put on, was like, you don't have cysts on your ovaries. I don't need to look at this. And so as much as there were many criteria change that have happened over the years, and this is not the first name change of this condition, right? But there have been a change. So now we know we don't require that. And we used to require this communication between the brain and ovaries. So FSH is follicle stimulating and LH is luteinizing hormone. We used to require that there was a 2-to-1 ratio between that. That went away. So there's been a lot of changes over the years in terms of understanding what actually is important in this condition. And so right now, what we know to be true is that we need to have some kind of like an irregularity to the cycle, right? And then we also are looking for androgenic signs and symptoms. So acne, hair growth, high levels of either a hormone called DHEAS in the bloodstream or high levels of testosterone in the bloodstream. These are kind of the main inclusion criteria that we have now. Cysts or follicles may be present on the ovaries. Some people do ovulate, right? And so this is where we have a syndrome, a group of symptoms that allows you to fit into a category where there's an appropriate management strategy, which includes, in some situations, hormone modification agents like birth control, always, and understanding that there's metabolic dysfunction, hence the name change. So understanding blood sugar regulation, understanding insulin, which is a huge piece. So there's always going to be that component of it. In our offices, we're always looking and assessing the communication between the brain and the ovaries, looking for any obstacles there. So we really can start to break down this condition and understand that cysts are just such a small part of it. So the name change to polyendocrine essentially means many hormone functioning systems. And then metabolic is the acknowledgement that almost everyone in this condition has a signaling issue with insulin, their metabolic hormone. And oftentimes there's blood sugar dysregulation. And then ovarian syndrome is acknowledging that it still very much impacts the ovaries. So we still can have increased testosterone production from the ovaries. We still can have an ovulation, meaning you're not ovulating every month and oftentimes having irregular periods. So that is anywhere from 30 days to months and months and months between menstruation. And so, again, it's very important that we are acknowledging that as much as at this moment, at the time of this recording, in May 2026, we have not changed any of the diagnostic criteria. This is an indicator that is coming. And this is a very important indicator that women, and just acknowledgement that women have risks associated with this condition that cannot be fixed by the birth control pill. And that's a lot of what I want to talk about today. So PCOS to PMOS. When someone was historically diagnosed with PCOS or is now diagnosed with PMOS, they are essentially diagnosed based on an ultrasound, based on the history of the regularity of their cycles, and based on their blood work. And so if you are in a traditional kind of medical office, then you will get that diagnosis and you will often be offered one of two things. One being the oral birth control pill, and two, in some situations, metformin, which is a blood sugar medication. So the birth control pill, the oral contraceptive pill, comes in many different forms. Okay. And essentially what this is a progestin. So it's not progesterone, it's progestin, and a synthetic form of estradiol called ethinyl estradiol. For the most part, that's what's included in these medications. Okay. And what it does is it has a very, very strong affinity for your receptors. So for your progesterone and your estrogen receptors. And so it makes your brain think there's large, large amounts of hormones and shuts down ovulation. So you may be saying, well, if I'm already not ovulating, why do we want to further shut down ovulation? It's a great question. Great question. Such an intelligent listener. But when we look at that, it is a way to control the amount of hormone production effort, right? And it is also a way to induce the shedding of the lining. So why is that important? Well, if you are trying to ovulate, so let's say your brain is trying to ovulate and consistently trying to push forward an egg. What happens is our brain, so FSH, follicle stimulating hormone from our brain, talks to our ovaries and gets our ovaries to make estrogen, natural estrogen, not synthetic, right? Natural estrogen. And that estrogen, in theory, in a healthy brain, will go back and trigger the release of something called LH, or luteinizing hormone, which causes you to ovulate. And so what happens in PCOS is that sometimes you can go months without even trying to ovulate an egg, but there are also many times that you make that attempt at ovulation and the static in the receptors prevents that LH spike from happening and being effective. And then you are in this resulting state where you have more estrogen than you do progesterone, because progesterone only comes after you ovulate. And over months and over time, that consistent environment where there's lots of estrogen results in the thickening of your uterine lining. It also can create immune changes. We're not going to talk about that today, but it creates this thickening of the lining. And that thickening of the lining can be associated with negative outcomes. So that can be associated with uterine lining cancers and a variety of other things. So it is very important that we do not have a lining that is too thick. That is facts. And so the conventional method for maintaining and managing that is to say, okay, let's just suppress the brain's attempted ovulation, therefore suppress that excess estrogen, and then also create an environment where when you take your sugar pill, all of a sudden those hormones drop. The brain's like, whoa, and the uterine lining's like, whoa, we don't have anything, shed a lining. Okay. So your brain thinks, oh, I went from being pregnant to not. And so therefore we're going to bleed. And so that bleed, the combination of not having a lot of that estrogen surging and not having the kind of underlying thickening of the lining, it creates a safer state. So I know where they're coming from with it. And I always say, like, I am someone who we work very closely with our nurse practitioners. I swear to God, I recommend prescriptions more days than not, right? Like, I am very, very pro whatever type of medicine my patients need, as is our whole clinic, right? Whether that is you need a birth control pill or hormone replacement therapy, or you need a medication for mental health or your immune system, what have you. Like, we are very supportive. And if patients don't want them, then that's fine. But this is one example where I don't think the birth control pill is actually the most indicated intervention in a lot of cases, because many times when we have a patient who comes in, their goal is to support their overall health. And their goal is to support their metabolic health and longevity. And so if you just go on the birth control pill, in some situations that can worsen insulin resistance and blood sugar signaling. That can create a state where you have more of this quote unquote fat storage hormone, insulin, that's not just contributing to weight gain because there is a lean PCOS pathway, but that's also contributing to more acne, to more hair growth, right? It's contributing to brain fog and fatigue and mood changes, skin tags, liver dysfunction. So another name change, we used to call it non-alcoholic fatty liver disease, and now it's metabolic associated fatty liver disease, right? So again, interestingly enough, we have this move in medicine to start to recognize the impact of the metabolic hormones, mainly insulin, and glucose regulation on a lot of these conditions. And it is no surprise that when you come to advanced women's health, we have our 5 to 7 causes of disease, and insulin and blood sugar signaling are primary. They're the main one. And so that we'll get into later how we're changing our treatment, which is, spoiler alert, we treated this the whole time. But anyways, we will get into the importance of that in a minute. So the birth control pill is just further suppressing the brain's communication to the ovaries. And so it is great, but there are other ways we can support. So you can do something called a progestin challenge. So the recommendation with PMOS or PCOS historically is that if you have not bled in 3 months, that you induce a bleed. So what you do is you take a progestin. So it's not progesterone. It is, again, a synthetic progesterone that induces, you take it, it builds up in the system. So your brain, again, is sensing, okay, we've got hormones here, and then boom, they're gone. And so that hormones to no hormones is what causes a shedding of the lining. So if you have a buildup of the lining, then it will result in you shedding that lining. Now, of course, it's not always going to be perfect. It's not always going to be complete. I help manage a lot of patients who do unfortunately have cancer in their uterine lining, or they have hyperplasia that is resistant to these progestins. So you still need an ultrasound, not every 3 months, but you still need an ultrasound. We still need to be mindful of what we need to do here. Okay. But that is the thought process with birth control pills. Then the thought process with metformin, which again is not prescribed all the time, but is prescribed sometimes, is that metformin is an insulin sensitizing medication. The goal with this medication is to make your fat storage hormones work better and more efficiently. So in theory, you have to make less of them, and it helps to reduce the insulin resistance, which I have many episodes on if you want to understand further, but it helps to reduce that. So therefore we get the decrease in weight gain, the decrease in hair growth, the decrease in acne, the decrease in skin tags, the decrease in risk of diabetes, the decrease in risk of fatty liver, etc., etc. So Metformin is still not always the standard of care, even though, again, that we expect to change to a certain degree because there's now this acknowledgement that there's multiple endocrine systems involved, which we'll talk about, and there is a metabolic component. So I imagine over the years, because over the next 2 years, they're planning to change guidelines across the world. So they have a kind of this 2-year period of time where we're going to be updating the naming and normalizing the new name. And then we'll probably look at diagnostic criteria. So let's just say in the next 5 years, there will be a much stronger understanding of how to metabolically support these patients, maybe before we are giving birth control. I will believe it when I see it that day. But again, I think it's important to understand where all of these things are coming from, because there's not a single person who gets into medicine to be like, oh, let's mess these patients up. No, we all get into it with a great heart. It's very important to acknowledge that. We all just have different tools.
Today's episode is brought to you by none other than Advanced Women's Health. If you are interested in diving in deeper to your health, if you are finally ready to feel like yourself, and you are finally over hearing everything's normal, everything's fine, and you want a deeper dive into your healthcare, then we are here to help you. We are currently helping patients in British Columbia and Ontario, Canada. But don't worry, if you're in another province, still reach out, get added to the wait list as we expand coast to coast. We cannot wait to work with you. Check out the show notes for more information on how to get started.
So let's get into the advanced women's health way of approaching PCOS. Because again, we take this integrative approach. So we are understanding what we need to do from a conventional perspective, but then also using nutrition, nutraceuticals, and the understanding pretty much across guidelines at this point is that PCOS, PMOS is a metabolic disorder. And this new understanding is now acknowledging that insulin and glucose metabolism need to be managed largely with lifestyle. It's acknowledging that there is a cardiovascular risk that is expanding far beyond just our ovulatory years, right? So in theory, can start before puberty and can extend until the day you pass. And so PCOS, when we're just looking at like cysts on the ovaries being something, that is a lot of times a really confusing thing to then manage when you're not bleeding, because I have hundreds of patients who have been told they don't have PCOS anymore when they go through menopause. It's like a graduation day. I'm like, it doesn't, no. You won't have a period anymore. Great. You may not have these immature follicles because you don't got no follicles, but there's no graduation. Like, we don't all of a sudden get to not have insulin resistance and all these other things. There is a cardiovascular risk, again, until the day you pass, just like the insulin resistance piece. So we also then are acknowledging with this name change that there's multiple systems involved. So it's not just the ovary, multiple endocrines. So we know, for example, endocrine organ is anything that's making hormones. So for example, we know that 30+% of women with PMOS or PCOS have hypothyroidism. So multiple endocrine systems. We know that the adrenal gland that's making cortisol, it's making DHEA, it's making our stress hormones, that is very involved in this condition. There's an adrenal subtype where we don't have high testosterone coming from the ovaries. We sometimes don't even have a lack of ovulation. We just have this high level of DHEA, which is an adrenal hormone. And even in those situations, we know there's a metabolic role there. And so when we're approaching care, we're looking and saying, okay, metabolic health, lifestyle management is primary. Cardiovascular disease management is key. Okay. Then we have the management of the other endocrine systems. Okay. So what's going on with your thyroid, what's going on with your adrenal health, what's going on with your stress responses, etc. Then we have ovarian management. So how much testosterone is coming out of the ovaries? How much do we need to manage there? We're looking at, is this a situation where you want to get pregnant and ovulation for the goal of fertility and pregnancy is primary? Okay, well, then we're considering that. If the goal is not to get pregnant, right, then we are saying, okay, well, here's what we can do to support you in the process of ovulating, because progesterone is still critically important whether you want to get pregnant or not. Progesterone only comes after ovulation. And it is an anti-inflammatory, calming hormone, very critical to overall health. So how are we supporting you with that? And then we look at, again, some of the, I'm going to call them more like aesthetic related goals, related to weight, body composition, related to androgenic symptoms, hair loss, hair growth, etc. So we're breaking that down. Then we're looking at the fatigue and mental health side of things. So we are still doing all of those things, with insulin being the big piece in the middle that we need to understand. This is why we do, on every person who has PMOS, PCOS, a 2-hour insulin glucose challenge test. So what this test does is essentially you go to the lab fasting. And again, we've got lots of episodes on this, but you go to the lab fasting, then you drink the sugary drink, and then half an hour, 1 hour, and 2 hours later, we test your blood again. So we can then see this beautiful little bell curve that will tell us how much insulin you need to regulate your blood sugar, how regulated your blood sugar is, how much insulin you make at fasting. And we're then able to customize a diet and lifestyle plan for you specifically. So when you're just doing the fasting tests, I can tell you what happened overnight, but I can't tell you what happens when you eat. And so much of this dysfunction happens when you eat. And so with that, what we're looking at is we're saying, okay, how many grams of carbohydrates can you consume? Should you fast, meaning go longer than 12 hours overnight without eating, or should you eat right when you get up? Should you eat every 4 hours, or what have you? We can time that out. We can, again, look at how much protein and what types of protein you should be consuming. We can give hyper-specific information. And it's something that I speak a lot, right? And so it's still one of those things that women are shocked about. Shocked that you can give that much information. And they're like, well, why would Weight Watchers or Atkins or like these different systems exist if I could have that much customized information? And the reality is weight loss is a multi-billion dollar industry. So there's always going to be different approaches and different styles for different companies. And that's great. But when the research exists, we're always going to use it. And so customizing a plan and then also retesting. So after you've done 3 to 6 months of treatment, retesting to understand your insulin status is really important, because again, we can re-customize your meal plan for maintenance. It's also, again, for women with PMOS, you should be doing one of these tests every year. And the reason I say that is because it is really easy for that insulin resistance to change, especially in perimenopause and menopause. So we then need to customize things further. So I think there's this understanding, and this is one of the things I'm really looking forward to seeing change, is there's this understanding historically that if you're ovulating, that the work is done. And it's a great thought process, but it's not accurate. And so when we are looking and saying ovulation is no longer just the goal in this situation, this is a metabolic condition that requires management and assessment of multiple endocrine tissues, brain, right? So what's going on with your FSH, LH, prolactin? What's going on with your thyroid? What's going on with your ovaries? What's going on with your adrenals? It requires ongoing assessment and management of at least those 4 endocrine tissues, right? Then we're looking and saying, from an insulin perspective, right, our pancreas, again, being a hormone producing, we need to assess that as well from a metabolic perspective. And that needs to be done on an ongoing basis. Again, at least every couple of years. And I still have so many patients that I've seen for 10 years, and they come in and they're like, okay, I fell off track, no problem. Let's just redo my testing. Let's look at my inflammation markers. Let's check in on whatever hormones need to be checked depending on their phase of life. Sometimes we're doing comprehensive investigations. Sometimes it doesn't make sense to check hormones. So we're looking at that, but we're fundamentally looking at metabolic health, metabolic hormones, what's going on with your liver. Do you have metabolic fatty liver disease? Have you developed that? Is your cholesterol creeping up? All of these things are very important to manage on an ongoing basis. And so my hope is that we really do see not only ovulation be the goal, but metabolic health be really educated upon. And also that we see that as women leave their childbearing years and go through perimenopause into menopause, that this condition is taken no less seriously, that we are still assessing and checking thyroid function and androgen function, and that we are still, well, I guess not androgens in menopause. I don't want to get any hate about that, but we are still checking insulin and we're still just really managing this condition, because the beautiful thing is it can be managed, right? You can have metabolic health. You can have a asymptomatic body with this condition without having to take hundreds of dollars of supplements a month for your whole life. That's not what this requires, but it does require strategic approaches. And so I am just really looking forward to the fact that we are going to hopefully see the change in diagnostic criteria coming up, and we are going to see a change in how we think about the management of this condition as a lifelong condition. So I won't go on any further, but I really do hope, if you have been struggling with symptoms that you feel are related to, again, what we used to call PCOS, but you've been told you don't have it, I hope you consistently look for the right person or someone at Advanced Women's Health to help you with that assessment. If you have not had a customized blood sugar related and insulin related meal plan and system set up, then by all means, reach out to us. If it's been a few years and you want to get reassessed, reach out to us. Like, this is something that we are so passionate about. And on our end, nothing's changing. Like, we are not changing, because we have known from day one that this is a multiple endocrine metabolic condition that's not just about your ovaries. So we're not changing anything. Our diagnostics, everything is still going to remain the same, because we will always provide the best evidence available care even before a name changes. So with that, I will let you go. But if you have someone in your life or yourself that needs support, always reach out to us. We have our onboarding coordinators. If you don't know who to work with, these are people who set aside 15 minutes to just sit down and talk to you about your needs and help match you with a practitioner. We have our new onboarding system, which I'm going to be talking about next, which I'm so excited about. So there's just so much coming, and Advanced Women's Health is not just a clinic where you can receive an appointment. We really are trying to create a community, and we're trying to create the support structures that women need to not only be able to get excellence in care, because that is what we will forever live and die by, is excellence will always be a part of my protocols and my team's protocols. But we also want to give you the environment that you can actually implement those protocols and do that in a really sustainable way. We are not in a place where people need to be paying thousands and thousands of dollars to get access to education and implementation support. If you want to do that, great. But we are so fortunate that we have the scalability now within our clinics to be able to give really, really affordable coaching and support options to our patients. So that is on the next episode, and I can't wait to share more. So have a good day.
Thank you so much for listening. I hope that you had as much fun as we did. And if you loved today's episode, share it with a friend and leave us a review. That is how we spread this message, and that is how we are going to revolutionize healthcare in Canada for women. Have a beautiful day and be well.